Hello everyone, my name is Jen Nolan and on behalf of Musculoskeletal Australia, I'd like to warmly welcome you to our webinar this evening on the topic of the impact of musculoskeletal conditions on intimate relationships, what to know and where to access help. I'd like to begin, however, by acknowledging the traditional custodians of the land from which we are broadcasting, the Boonwurrung people of the Kulin Nation, and pay my respects to their elders, past, present and emerging. Musculoskeletal Australia wishes to sincerely thank Janssen Australia for their sponsorship of this evening's webinar, which has enabled us to offer it free of charge. It is important to state, however, that our sponsor has had no editorial control over the content of tonight's webinar. Tonight's webinar is the final one in our 2022 series, but we have a great list of webinars planned for next year, covering conditions such as rheumatoid arthritis, osteoarthritis, complex regional pain syndrome and neck pain, as well as current issues such as medicinal cannabis and the importance of sleep. Anyone who registered for our webinars in 2022 will be automatically registered for the 2023 series, just to save you the trouble of registering yourselves. Our main presenter for this evening is Professor Alana Ackerman. Alana is a musculoskeletal epidemiologist in the School of Public Health and Preventive Medicine at Monash University and an experienced orthopedic physiotherapist. Her research program aims to understand the personal and societal impacts of osteoarthritis and the best ways of measuring the outcomes of osteoarthritis care. Alana is an osteoarthritis expert for the Global Burden of Disease study, and she's been involved in the development of models of care and clinical care standards for osteoarthritis. After an initial presentation, Alana will be joined in discussion by Laura Restow, a senior physiotherapist with the Central Coast Local Health District in New South Wales, who has worked in women's, men's and pelvic health in both the public and private sectors. As well as Brooke Dobbo will also be joining Alana, who is also an experienced women's and pelvic health physiotherapist based in Queensland. We're very grateful to Alana, Laura and Brooke for presenting this evening's webinar. And without further ado, I'll hand proceedings over to Alana. Thanks very much, Alana.
Thank you, Jen. Thank you for the introduction, and thank you to Musculoskeletal Australia for the invitation to present this evening. It's a pleasure to be here with you all. This is undoubtedly a personal and sensitive issue that is rarely spoken about, but it's an important issue for people living with chronic musculoskeletal conditions and their families, and for health professionals too. To give you an overview of tonight's webinar, I'm going to start with some background about chronic musculoskeletal conditions and their impacts on intimate relationships. I'll talk about what we know from the current research and also about the impacts of osteoarthritis and hip replacement surgery. We'll then move on to a panel discussion with two fantastic panelists who I'll introduce to you shortly, and then we'll have time for questions from the audience. It will come as no surprise to anyone tonight that chronic musculoskeletal conditions are extremely common around the world. In Australia, we have data from the most recent National Health Survey, which estimates that chronic musculoskeletal conditions affect 3 in 10 Australians. It is estimated that nearly 7 million Australians have a chronic musculoskeletal condition, with back pain and the various forms of arthritis being the most common. We also have important information from the Australian Burden of Disease study, which looks at a range of different health conditions. This study has shown that musculoskeletal conditions are a leading cause of non-fatal disease burden, or what we refer to as the number of years lived with disability. And this is particularly the case for middle-aged and older Australians, although we know that younger people are impacted as well. And if we look at this graph, we can see that musculoskeletal conditions come second only to cancer as a proportion of the total disease burden in Australia. And this is comparable to the burden for cardiovascular diseases and mental health and substance use disorders. We know that the impacts of musculoskeletal conditions are wide-ranging, and certainly they are not limited to pain and stiffness, although these are very common symptoms. There can be impacts on walking and activities of daily living, for example, dressing and activities around the household. There are also impacts on both paid and unpaid work, and also with respect to fatigue and sleep. We know that there are impacts on mental and emotional well-being, and it's not surprising that there are impacts as well on overall quality of life. But there's a missing piece here that often gets overlooked, and that is intimate relationships and sexual function. And this is despite the World Health Organization recognizing that this forms a very important part of overall health and well-being. Before I talk about the current research in this area, I think it's also important to acknowledge what we don't yet know. So firstly, we don't really understand the experiences of people who are in non-heterosexual relationships. And this is largely because the studies that have been conducted so far have mostly focused on people in married relationships. We also have very little understanding of the experiences of people who identify as non-binary, and that's because most of the studies in this area refer to men and males or women and females. And in tonight's webinar, we use inclusive definitions of men and women, including transgender, gender diverse, and non-binary individuals. So what do we know from the current research? Together with Andrew Briggs and Sharon Van Dornum and our colleagues, we have published 2 systematic reviews which have looked at all the evidence on this topic. Our first systematic review looked at the impacts of inflammatory arthritis on intimate relationships and sexual function. And we reviewed 55 studies which involve people with a range of different conditions, including rheumatoid arthritis, psoriatic arthritis, lupus, ankylosing spondylitis, and spondyloarthritis. Our second systematic review looked at the impacts of non-inflammatory musculoskeletal conditions on intimate relationships and sexual function. And for this review, we looked at 51 studies that involve people with conditions such as fibromyalgia, low back pain, chronic widespread pain, and osteoarthritis. For both of these reviews, we focused on studies that investigated people's concerns, their thoughts, beliefs, and opinions about the impacts of persistent musculoskeletal pain on their sexual function, sexual health, or intimate relationships. And we identified a range of common themes from these studies, which highlight the many and varied impacts that chronic musculoskeletal conditions have on people's intimate relationships. And some of these impacts included having to stop sexual activity due to pain, reduced desire or pleasure due to pain or the expectation of pain, the impacts of fatigue, reduced frequency of sexual activity, pain with sexual activity or intimate touch, altered relationships with a partner, fluctuations with different disease flares, having to use alternate positions for sexual activity, erectile dysfunction, the impacts of pain on body image, sexual identity and self-worth, and embarrassment and frustration that was associated. I also wanted to show you tonight 3 graphs which highlight further some of these impacts. So the numbers in this first graph represent female sexual function index scores from different research studies. The orange bars are for women with inflammatory arthritis, and the blue bars are for women without inflammatory arthritis. And the black horizontal line is a threshold where any score below that line can be considered as sexual dysfunction. And what we can clearly see here is that all of the orange bars fall well below the black line. And for all of these studies, women with inflammatory arthritis had the lowest scores. This next graph shows the same pattern for men when we looked at their international index of erectile dysfunction scores. We can see that all of the orange scores fell below the black line, and in all of the studies, men with inflammatory arthritis had lower scores than men without inflammatory arthritis. I'm just trying to change the slide. There we go. And this final graph shows a similar picture for women with fibromyalgia, chronic widespread pain, and low back pain, where the groups of women with pain in orange and the groups of women without pain are in blue. And what we can see here again is that women with the pain conditions had lower scores than those without pain. And if we pull all this evidence together, what it's telling us is it's highlighting just how common sexual dysfunction is among women and men with chronic musculoskeletal conditions. Moving on specifically to hip osteoarthritis and hip replacement surgery, we know that hip osteoarthritis is a very common musculoskeletal condition and that it's associated with pain, stiffness, and reduced joint mobility. There's been a number of studies in this area, and they've also shown that sexual dysfunction is relatively common in people with hip osteoarthritis before they have hip replacement surgery. And one study, as shown here, found that on average, 77% of people with hip osteoarthritis reported sexual difficulties due to their hip. And these difficulties actually started well before their hip replacement surgery, on average about 2.5 years before they had surgery. But despite these findings, it's also very clear that surgeons rarely, if ever, discuss sexual activity with their patients. There are some studies that have shown that patients can experience improvements in their sexual quality of life, sexual satisfaction, and the frequency of sexual activity after hip replacement surgery. And there are various resources available if people are concerned about sexual activity with their new hip after hip replacement surgery. There are recommendations that have been published for safe sexual positions to avoid dislocating the new hip. And these types of resources include available leaflets or websites, and there's also several booklets that are publicly available, and I've just listed some examples here. We'll talk more about this in the panel discussion, but it's important for people to know that help and support is available. I've only just given a few examples here on this slide, but some of the available resources include Musculoskeletal Australia's telephone helpline, which is staffed by a trained nurse. There's also the Australian Physiotherapy Association Find a Physiotherapist website, and it has a search function so you can select the type of physiotherapist you may be looking for example, a musculoskeletal physiotherapist or a women's, men's and pelvic health physiotherapist. There's also the Society of Australian Sexologists, whose website has a member search function as well. And I've just put up here an example of one of the booklets that's freely available online for people who are considering hip replacement surgery and for after surgery. And this is an information booklet that's published by one of the NHS trusts in England. I'm now very pleased to introduce our panelists for the discussion tonight. Thank you. We are extremely fortunate to have two highly trained and highly experienced physiotherapists on the panel here, and I'm sure you will find their expert insights very valuable. The suggestions and advice that you'll hear tonight are intended to be general in nature, and if this is relevant to you, we do encourage you to seek professional advice that is specific to your own health and your own circumstances. I'd first like to introduce Laura Worthing. Laura is a titled Continence and Women's Health Physiotherapist. She's currently working as a senior physiotherapist in continence and women's health with the Central Coast Local Health District in New South Wales, and has previous experience working at the Royal Hospital for Women in Sydney and in women's and men's health in private practice. She has a master's in clinical physiotherapy and a graduate certificate in continence promotion and management. Laura has been the chair of the New South Wales Australian Physiotherapy Association's Women's, Men's and Pelvic Health Committee for the last 4 years and continues to volunteer as a committee member. She has previously published research on the impact of inflammatory arthritis on sexual function and intimate relationships. I'd also like to introduce Brooke Dobo. Brooke is a women's, men's and pelvic health physiotherapist at Vera Women's Wellness, just out of Brisbane, and at the Wesley Hospital in Brisbane. Brooke has been a member of the APA Women's, Men's and Pelvic Health Committee for 8 years and more recently has been the vice chair of this committee. She teaches in women's health at Bond University and in women's health courses for the Australian Physiotherapy Association. Brooke is currently completing her Masters in Pelvic Floor Physiotherapy through the University of Melbourne and has a special interest in sexual health, including sexual pain and sexual dysfunction. Laura and Brooke, welcome. I've briefly summarised your current roles, but can you tell us a little bit more about the type of work you do each day and also the range of clients that you both work with in your clinical roles?
Yeah, so in my public health district, I work across 2 different part-time roles. So one is the senior continence women's health role, which I work in 2 days, and then I work in a community physiotherapy role for 3 days. And through these roles, I see a range of different patients. Within the continence women's health role, I see women through our outpatient physiotherapy clinics during their childbearing years, so that present with low back pain or pelvic girdle pain, incontinence with their bladder or bowel, or pelvic organ prolapse, where either the bladder, the bowel, or the uterus may descend into the vagina, creates a heaviness or a dragging sensation. And I also see young women that before their childbearing years that present with sexual dysfunction, with whether that might be due to chronic pelvic pain or endometriosis or pain with periods. I also see, similar to with the women after they've had babies, particularly in our gynecology clinics, where we see perineal tears, where that scar tissue from the perineal tear on episiotomy might cause some pain or discomfort for them. And I also see a number of women during menopause or post-menopause through these gynecology clinics that also present with incontinence or prolapse or chronic pelvic pain, which often presents with some sexual dysfunction or coital incontinence, so leakage of urine during intercourse. But also in private practice in the past, I've seen a number of men pre and post prostatectomy, and these men often present with erectile dysfunction as a result of the surgery, and a number of them have also been on androgen deprivation therapy or radiation therapy, which also can contribute to erectile dysfunction as well. So I've treated a number of those men in my time as well, but in the public sector, the continence nurses primarily see those men on the Central Coast. And then lastly, in the community role, I see quite a broad range of patients. So patients that have had a stroke or neurodegenerative conditions like multiple sclerosis or MND. We see patients that have in the elderly population that need falls prevention, or have respiratory conditions like bronchiectasis or emphysema, or patients that have had fractures or orthopedic surgeries for their hip and their knee. So yeah, we see quite a few different types of patients in our practice, which is great.
Thanks, Laura. I think you've covered just about the whole general public there. Thank you. Brooke, would you like to tell us a little bit about the sort of work that you do on a day-to-day basis?
Absolutely, yes. And I was going to say that with that amount of experience, I'll be sending anyone in New South Wales your way. But it's just incredible. But yeah, similarly to Laura, I do see a wide range of conditions, namely men and women with pelvic floor dysfunction, and similar to Laura, I am so fortunate to have the mix between acute hospital and outpatient or private practice setting. So just to give you an idea of in the hospital what I would see, often I'd be traipsing the wards of the urology ward. So like Laura mentioned, often I'd see men post prostatectomy, and if I'm lucky enough, I can sometimes actually see a man through his whole journey from when he's first diagnosed with prostate cancer, so coming to see me prior to surgery, seeing him on the ward, which is so nice. It's that continuity of care, that familiar face. Sometimes even at the trial of void, which is when he comes back for to take the catheter out, and then back again in the clinic afterwards. So it's really nice to have that mix when it works out. It's really lovely. Other wards that I would commonly see would be the gynae ward. So seeing women on the gynecological ward and of course the maternity ward after having a baby. And in my private practice, I'm so grateful and fortunate to work in the most beautiful holistic women's centre. It's called Vera Women's Wellness. Probably I do see a great breadth of patients there, but the most common patient that I would see would be persistent pelvic pain, often presenting with lower back pain and hip pain, and it often is on the background of physical and or psychological trauma. Unfortunately, almost always comes with issues with sexual function, and so this is an area that I have a special interest in and very passionate about, and I very much enjoy helping this patient population.
Thank you, Laura and Brooke. I think we can all agree you have a vast expertise between the two of you. Laura, you've worked with many different health professionals across lots of different sort of clinical backgrounds. Why do you think that health professionals don't routinely ask patients about the impact of health conditions on intimacy and sexual function?
Well, I think there's a few reasons. I think one, particularly for clinicians working in the area of musculoskeletal conditions, it's often not a general part of their training. So whether that's their undergraduate training or in some cases too their postgraduate training, sexual dysfunction isn't often taught or educated on in terms of the assessment and treatment. And as a result of that, often clinicians then think it's not part of their scope of practice in order to then discuss that with their patients, or they then think that it's a different clinician's role. So it often then sort of gets palmed off, but then other clinicians also think the same, that it has been covered by someone else. So unfortunately, I think in a number of patients' cases, then it's not covered at all. I think some of the other difficulties also time constraints, as I'm sure Brooke finds in her practice too. You know, we're very limited with the amount of time that we have with our patients, and that's even more so with the medical profession, with the amount of time they get with their patients. And I think also too, it's to do with the clinical documentation that a lot of clinicians use, that it's not part of our routine clinical documentation to discuss sexual function. And I think too, this also is a bit of a problem, that then clinicians don't necessarily know who to refer on as well, because they're not regularly discussing it. So I think there's some of the main sort of issues that clinicians do face. And I think just, I'll last say just sort of one other is also the lack of privacy for patients as well. I think a lot of my musculoskeletal colleagues that work in outpatient clinics where you only have, you know, a curtain to shutter out, you know, privacy, you know, everyone else in the other cubicle next door can hear your conversation. So I think that's also another contender as well, or if that patient brings along a family member or a friend or carer, I think clinicians then are a bit begrudged to discuss it, you know, knowing that they don't have that privacy for the patient. They're out of respect for their patient. They're not wanting to discuss it on that visit.
Sure, great points. Thanks, Laura. And Brooke, following on from that, why do you think it's so hard for us as patients, consumers, to raise this topic with our health professionals when we go and see them?
So I guess there still is stigma, isn't there, on this topic, and it's quite a taboo topic in society, and unfortunately it can bring feelings of shame, especially in a professional setting. I do like to believe that it's changing slowly, very slowly, and you know, I guess that is the aim of tonight, to advocate for how important these conversations are to have, and I guess give everybody a little bit of advice on how to start those conversations. And I think, you know, I think people might actually realize that they are easier conversations to have than you might anticipate. There might be a lot of fear about starting those conversations, but you know, once you have the conversation, it can actually provide a lot of relief to finally be heard about a topic that's, you know, hasn't been able to get off your chest for a while.
Great, that's great, Brooke. And we're definitely going to have some conversation tonight about some sort of practical ways that you might be able to bring up this topic with your health professionals. Brooke, if someone does have a concern about their chronic musculoskeletal pain and the impact that that's having on their intimate relationships, where's a good place for them to start accessing help and support and advice?
Yeah, so, well, I was going to say, I hope that everyone watching this evening or watching the recording has access to a trusted, wonderful musculoskeletal physiotherapist. And if they don't, then using that tool that Alana said, and we'll put it at the end as well, the Find Your Physio on the APA, because physios are well placed to, you know, get back to basics. We assess function and functional limitations, you know, and if we use the ICF, so the WHO, which is the World Health Organization, a bit of a mouthful, International Classification of Functioning Disability and Health Framework. It's very, like, it breaks it down. The basically, like, function and body structures is what physios assess very well. So it can be as simple as assessing range of motion of a joint that might be restricting or a barrier. It might be endurance, pain, the source of pain. And so from that, they can then offer, treatment options that might be quite simple. For example, offering positions like those guidelines that we mentioned after hip surgery, very practical positions for intimacy. Also, if you have an issue and you haven't brought it up with any health profession yet, I'll be an advocate for our career here, but a women's, men's and pelvic health physiotherapist is actually a really great first practitioner, like first contact. And that's because, we are well trained to do a very comprehensive, interview or subjective examination, and we're comfortable to ask the questions. The other thing too, what Laura mentioned, and it is true often in a musculoskeletal physio practice, you're going to be in cubicles, without privacy. Whereas when you're going to see a pelvic health physio, it will be a really safe space. There's going to be pictures of pelvic floor and whatever else, poo charts on the wall. So it's going to be an easy place to have the conversation. So a really, really good option. And lastly, of course, and I say this to all my patients actually, as well as friends and family, that it's so, so important to have a good GP, because, you really want a general practitioner that you can feel comfortable and safe to have these conversations. It's so, so important, and conversations about anything really. And if you don't, I really encourage people to look up even, Google holistic or integrative GPs, that they might be more comfortable to have those conversations. And of course, your GPs are going to be, you want them to have solid referral pathways to know exactly where and when to refer. Yeah.
Fantastic, and we'll come back to those sort of referral options a little bit later. But Laura, what are some really practical tips for how someone can raise these types of issues with a trusted health professional? Was there any particular kind of language they could be using? Do you have any tips to make that easier? And do you have any tips for helping that health professional understand that this is a really difficult conversation that you're trying to bring up?
Yeah, definitely. And look, I think that's a good way to even preface the conversation to begin with, to say, look, I really want to talk to you about something that is quite difficult for me to discuss, but it is really important to me and it's quite a concern. And I think you can then further link this to your goals, and that's something that us as health professionals are really focused on, working in healthcare, this current climate, is what our patients' actual goals, because we want to direct our therapy and our interventions and our assessments towards what each of our patients' goals are. And I think that's another thing that we can also then think of when we're trying to discuss this topic with our therapists, is link it back to some of the functional things that you're having difficulties with. So for example, as Brooke was saying there, with different positions that might be uncomfortable for the hip or their back pain as well. Thinking about, whether that's cleaning the bathroom floor or the shower, particularly in that sort of 4-point kneeling position, and link that back to sexual positions, or the same as lifting and bending, picking up grandkids, and that's difficult for them. But also that, sexual positions, particularly sideline, where your hips and knees are bent up and your back is flexed. Or similarly to thinking of patients with back pain, where standing for a long period of time aggravates their back pain. They could also link this to their therapist and saying, well, it's also uncomfortable when I'm extended with my back in that long position with intercourse if I'm on top of my partner as well. So I think that's another little way that you might link it back in to your health professional and tie it in with what they can actually assist with. Because as Brooke was saying, general musculoskeletal physios can assess that joint range. They can look at the strength and endurance, all of those things which would then help your sexual positions to be able to have a sexual intercourse and intimacy with your partner. And then I think lastly too, maybe just avoid sort of using colloquial language or slang when you're trying to have that conversation about sex and intercourse, so that you can really highlight to your health professional this is something important to you and an important part of your health care, to avoid sounding inappropriate, I guess, to the healthcare professional. So I think just having a bit of a think about the language that you might use, I think that can also be helpful. But I think paramount is then bringing it back to your goals, and that intimacy with your partner is a big part of your goals for your therapy, whether you've got back pain, hip pain or knee pain.
Fantastic.
Oh, and lastly, I just thought too, another useful tool might be also bringing along some written information. So maybe bringing along some of the brochures that Alana's mentioned, or even using a patient-reported outcome measure that us clinicians often use, like the Female Sexual Function Index that Alana was talking about before, or the International Index of Erectile Function too. So filling out something like that to then, start that conversation with your health professional might be a useful way to open up that conversation, having that written material in front of you.
Great suggestion.
If that's
please
okay.
do. Yes, please.
Just a tip on what words to use. I personally love using analogies. I use them all the time just because they make sense to my brain and they're a nice way to explain things. I don't know if anyone's heard of Dr. Emily Nagoski. She's a writer. She's written a few books. She's a sex educator and researcher. She's done a PhD over in the States. She uses lots of analogies in her literature, and so I often use them. One of her most famous it's called the dual control model. And so basically it talks about libido, which is often almost always going to be affected in these scenarios. And so she talks about the brakes and the accelerators to one's libido. And so if we talk about libido just for a second, to have libido, you need to have desire there, and it's very, very difficult to desire something that is painful. So a really great way to explain that to a health professional would be to say, I've got very sensitive brakes to my libido, and that is my pain. So that's just some nice kind of language that you can use, and you can be creative with your analogies to explain it. And like Laura said, just using softer language rather than slang as well.
Fantastic, great suggestions. Thank you both. Brooke, there's a range of different health services that might be available to people. Can you talk us through some of the different options for health professionals who can help people with intimacy and sexual function issues if they have a chronic musculoskeletal condition?
Sure. Now I could probably spend a whole hour answering this, so I'll try and summarize it as best as I can. So sexual function can indeed be quite complex, and there may be several contributing and compounding factors. So if I'll list off a few like specialists and the conditions that they might treat that might be contributing. So firstly, you could consider a urologist, so anything to do with the bladder. So for example, bladder pain syndrome or interstitial cystitis. For men, of course, erectile dysfunction, like we've mentioned, particularly post-prostatectomy. A gynecologist. So here's a mouthful, but it is the correct term and it's very common. It's called genitopelvic pain penetration disorder, or GPPPD for short. Essentially what that is, it's naming dyspareunia or pain with sex. And like I mentioned before, that's a common condition that I would see in my private practice that the gynecologist refer to us for, same with Laura. Other things that a gynecologist would help with would be painful periods, endometriosis, persistent pelvic pain, lots of P's, isn't it? Peri and post menopause, and also postnatal. And actually, I'll point out here that hormonally, there's actually they're quite similar in that post-menopause and after having a baby, especially for women who are breastfeeding, basically estrogen is flatlined. And so what that's going to mean is a lack of estrogenization of the vulval tissues and the vagina. And there is a direct correlation between that. And that's going to lead to vaginal dryness and dyspareunia, particularly superficial pain with sex. And then other specialists might include gastroenterologist or colorectal specialist for gut issues that are causing abdominal pain and contributing to pain and function. Even dermatology, particularly vulval dermatology for any vulval conditions. Also rheumatology for joint conditions, managing medications, same with pain specialists as well. And one actually that we haven't even mentioned yet that is probably should be on the top of my list, and that is psychology, counselling, or sex therapy, particularly. And again, almost always, relationships are going to be affected, intimate relationships. So couples counselling can be so effective in this space.
Fantastic, thank you. Do you both have any suggestions for when it's the best time for people to be bringing up these issues with their health professionals? Is it at the first appointment? Is it further down the track? Is there a best time?
I can answer that one. Yeah, it's a really good question. And I guess it's going to depend what Laura just mentioned before. Think about what your goals are and also what your priorities are. Perhaps it is a priority and you want to bring it up, so then it probably is a good idea to bring up in the first or one of the first consultations. You might like to start a sentence like, I have something difficult to talk about, and your clinician or your therapist is going to listen, and they'll know that there's an important topic to talk about. If you've got a whole bunch of goals and sexual function happens to be on that list, you might start off by working towards an ADL, an activity of daily living, or returning to sport or running, for example. But it's still important, and you want to mention it, and it's one of your goals. What you might like to do is plant the seed and mention it right at the end of an appointment, or of the first appointment, and that way it's going to make opening up that conversation at a subsequent appointment much easier. So that would be my advice on that.
Fantastic, thanks, Brooke. You both have expertise in working with clients with diverse identities and experiences. Do you have any advice for people from LGBTQIA+ communities, particularly those who identify as trans or gender diverse, in seeking help with intimate relationship issues around their chronic musculoskeletal pain? Laura?
Yeah, look, I think particularly for people that identify trans or gender diverse shouldn't be hesitant to seek help. I think these types of conversations are difficult for anyone to have regardless of background. And I think particularly for health professionals like myself and Brooke that spend a lot of time talking about sex and sexual dysfunction, we are very inclusive of all sexualities and really aim to provide holistic person-centered care. But I think that's true of any general physiotherapist or occupational therapist or medical professional for that same matter. And I think a lot of what we do when we talk about person-centered care is looking at that goal-directed therapy and what's specific to that patient or what they really want to achieve. So not necessarily the treatments or assessments we offer are any different, but we just look at targeting them depending on that patient's goal. And I guess that's, as Brooke was saying before, in terms of when do you bring up these conversations, it's looking at when that, when that goal is your priority. But there might be some goals that link in together too. So as we were talking before, when we were saying about lifting and bending to pick up grandchildren, but also, the sexual dysfunction that you're experiencing from your hip or your back pain might intertie or interlink together. So you might actually concurrently work on those two goals together with some of the things that your physiotherapist might be getting you to do in terms of your therapy.
Great suggestion. Thanks, Laura.
Yeah.
Thinking about, many people with inflammatory arthritis, for example, would be seeing a rheumatologist regularly for their care. If somebody was going to then see other types of specialists for some of these sort of sexual function issues, how would those specialists work together and communicate with the rheumatologist or other people involved in care?
Yeah, such a good question. And To be honest, as I'm sure you guys know, there's really only been research in this space for very recently in the last few years, particularly if we're talking like chronic pain, particularly chronic pelvic pain, and even more so women's health. But thankfully, the government is finally putting the money that needs to go into it. But what we do know from recent research is that the gold standard for treating at least chronic or persistent pelvic pain is by a multidisciplinary team. Even better, I'll call it interdisciplinary team, alluding to the fact that it is a team and that we're communicating. And so, yeah, like I mentioned, it can be quite complex and there can be quite a few specialists and or allied health involved. And it's absolutely crucial that the team are communicating to get the best care. And, you know, like it's not just going to be about an excellent gynecologist, for example, or an excellent women's health physio. We are all going to form the puzzle pieces of the care, yeah, to get the best out of it. Do you have anything to add to that, Laura?
The only thing I think I'd say too from my community experience is I guess more formally we often do a case conference with the multidisciplinary team, and that might be something that as a patient you could advocate for to you know, create your own multidisciplinary team in, you know, bringing in the different professionals that you feel like you need, or working with the current health professionals you have to see who else might be needed to be involved, and then pushing for something like a case conference where you as a patient instigate having an appointment with a number of those clinicians together in order to push forward to what your goals are.
And that way, I guess your GP and rheumatologist would be across all of the sort of issues and the treatments that are currently underway, which is good too. All right,
and even written communication too. Just the GP letters back and forth as well, I think can be really useful, or picking up the phone and communicating in the room with them.
Yeah,
sorry.
That's really important too. That's all right. I think we've probably got time for just one more quick question before we hand back to Jen. But I guess it's pretty common these days for patients to be asked to fill out different types of questionnaires when they go and see a health professional. With regard to sexual function, is this something that's commonly done? And sort of, can you give a bit of a quick outline of the types of questions that might be included, just so it doesn't necessarily come as a shock to people when they're asked to fill out these questionnaires at an appointment?
Yeah, of course. And these are the questionnaires we were referring to before, like the Female Sexual Function Index, the International Index for Erectile Dysfunction, or one that Brooke and I commonly use is the Australian Pelvic Floor Questionnaire as well. But these are basically what we call patient-related outcome measures, and these can often be used as just even a screening tool to screen if a person has sexual dysfunction in the first place, but more commonly we then use it as an outcome measure to see if the person's having improvement in the treatments that we're providing, so we can track their progress. I guess commonly some of the questions these questionnaires might ask, usually around you know, the level of sexual desire, arousal, as Brooke was talking about before, whether you're able to experience vaginal lubrication or achieve erectile rigidity, whether you're able to reach orgasm or ejaculation, you know, your satisfaction with relationship intimacy, whether you're having pain with penetration, and I guess overall, you know, what level of satisfaction are you having from your sexual function and intimate relationships. So that just gives you a little bit of an idea of the topics that they would cover.
Fantastic, Laura. Thank you. I'd like to thank Laura and Brooke for their expert advice and insights. I think this has been a really useful discussion for people who are living with common musculoskeletal conditions, and also any health professionals who may be listening. We're now very happy to take any questions that you may have. Thanks, Jen.
Thank you very much, Alana, Laura and Brooke. Look, I should have said at the very start of this evening, just what fantastic work you're doing to actually look into, really investigate, to offer services in this area, because it is so vital. And as you sort of said at the very start, Alana, it's just not discussed or covered or addressed. And I think you mentioned, Brooke, about the fact that, you know, there is a lot of stigma and shame around even raising this. So I think the discussion that you've had just now has been really worthwhile, to really give a few tips and ideas to people as to, you know, I think even having an understanding why some health professionals don't bring it up. You know, it was interesting that, as you said, Laura, they often feel like it's not actually part of their role, and they're certainly not sort of educated to do so when they first do their training and so on. So I think this work you're doing is just so vitally important, and I hope that gradually you'll be able to not only provide consumers with information as you're doing this evening in this webinar, but also, you know, really reach out to health professionals and realise what a great sort of gap there is in sort of not really addressing the whole issue about sort of sexual dysfunction and intimacy and the impact of musculoskeletal conditions on those two aspects. Now, believe it or not, we've actually had no questions coming through. I think this is the first webinar that I have ever done where there's no questions coming through. I'm not shocked by that, because I think it is the sensitivity of the issues that people are probably, I'm sure they've all been listening. And as we said at the beginning, this recording will be invaluable, and I'm sure it will be viewed many times. But I think people have just taken on board what you've covered and offered this evening, but probably understandably, maybe a little bit reluctant to ask questions, which sometimes I know based on our other webinars, it can be quite personal in nature. So I think people are taking information in, but they're probably, so look, the fact that there's no questions is not sort of surprising for the topic, because I don't think we've ever had a webinar where there's been no questions posed, but I think that just indicates the sensitivity and the bravery of covering this topic tonight. So I thought some of the things I would be handy to know, Brooke, that the GP or doctor, the researcher in the USA that used the analogies and so on, I thought that was a really good sort of suggestion as to how people might sort of raise topics with their health professionals and so on.
Yes.
Also that idea of even sort of just putting your toe in the water towards the end of a consultation or a sort of a session with to sort of like, you know, raise the issue for discussion next time. I thought that was a great idea. And it's interesting what you were sort of saying, Laura, about the fact that it's often difficult for maybe clinicians, apart from their own personal maybe sort of insecurity about raising these issues, often wouldn't know who to refer to, and then you've got the time limitations also sort of governing any consultation, which also makes it very, very difficult. There's a message that's come through. Oh yes, now I was just going to bring up that slide again, Alana, with the resources on it. Someone has sort of said, thank you very much. Again, can you remind people where to find pelvic floor physios? There we are. We've got this one here. So, Alana, you were saying this, the APA, the Australian Physiotherapy.
That's the APA. So that's an opt-in sort of member search website. So people who are in a specialty sort of area or have a particular focus in physiotherapy, they can sort of have their name included in this search function. And when you go to that website, you can select by geographical area and you know, metro, regional, rural as well. And then there's that drop-down box with practice areas. So you can choose any of those practice areas, and probably, you know, the women's, men's and pelvic health physiotherapy area will be a great place to start, remembering that all physiotherapists are initially trained across all of the various areas of physiotherapy. So when you go and see a women's, men's or pelvic health physiotherapist, they are also trained in musculoskeletal assessment and treatment as they are in cardiorespiratory and neurological areas of physiotherapy. So they do have that background knowledge, plus they've got the added training and expertise in women's, men's and pelvic health. So that's a great place to start. Jen, as you were talking then, the other thing I thought of in terms of, excuse me, people bringing up the topic at a consultation with their health professional, and obviously recognizing just how challenging that can be. If people don't feel comfortable to raise that verbally with their health professional, there's absolutely nothing wrong with writing that down beforehand and bringing it in on a piece of paper that you can hand over to your health professional and say, look, this is really hard for me to bring up. I've written down my thoughts beforehand. I'd really appreciate if you could have a look at this. So I think that's also a way that people consider if they just don't feel comfortably to bring it up verbally. Laura and Brooke, do you think that's an appropriate strategy? I think that might be a bit easier as well sometimes.
Absolutely.
Laura, Laura and Brooke, in your experience, have you had actually someone who has done that? It sounds like a great idea.
I actually probably haven't, but in saying that, I think because as Brooke was saying, our subjective history taking is very thorough in how we discuss. And I think too, because we see patients every day and, you know, numerous patients with sexual dysfunction where we're talking about these intimate topics, whether it's bladder or bowel incontinence or whether it's sexual dysfunction, we're very comfortable and I think good at creating that safe space for our patients, and also building, it takes time to build that trust and rapport with your patients as well. So I think, you know, covering those aspects, I think it probably hasn't come up so much for us as women's and men's pelvic health physios, but I can totally understand it happening in that situation with a musculoskeletal physiotherapist that maybe doesn't sort of speak about those topics on a day-to-day basis like we do.
And look, I think, you know, the average person in the street is probably not aware that there are sort of specialist physiotherapists. Yes. People just talk about physiotherapists and so on, but, you know, there's musculoskeletal physiotherapists, there's, you know, pelvic health physiotherapists and so on. So really, I would strongly recommend to people that they do look at the Australian Physiotherapy Association website to look up, you know, if you're really looking for a physiotherapist who has specialised in a particular area, because you know, I think the wealth and depth of knowledge that those sort of specialised physios have really, you know, very evident.
And just to add to that as well, Jen, also in other specialties, you know, in general practice with GPs, there are GPs who will have a special interest or additional training, whether that be in women's health or men's health. So often that's the sort of information, if you go to like a GP practice website and they list all their doctors there, there'll often be some dot points underneath about special interest areas. So that might be a way to look out also for a medical practitioner who's got a special interest in that particular area too.
Yeah, great suggestion. And Brooke, you made a comment about the fact that maybe the government's starting to realise how important sort of pelvic health was it generally, as if there was sort of maybe funding becoming more available in the area? Could you just elaborate on that?
Yeah, it's something I'm very passionate about, working in women's health, that historically, just in general health, in bone health, in cardiovascular health, in sports and fitness, the majority of research has been done on healthy, normal male subjects. And it's just quite interesting, and it's really only sort of had light shed on it in recent years that, well, hey, we're actually women, or, you know, biologically assigned female at birth, are quite different to men physiologically. And so, yeah, thankfully, research in all different realms is coming out now, and I guess really it's got to do with our hormones, doesn't it? Because we're cyclic creatures, whereas, you know, men have a 24-hour hormonal cycle with the sun, and women are generally, give or take, 28-day cycle. And so, but it's quite fascinating, the research that's coming out, isn't it? Yeah. I see you nodding, Laura. Yeah. And then I guess more specifically, pelvic pain, namely endometriosis, the Australian government released a national action plan in 2019. And so since then, there's been a lot of advocacy and research coming out in the pelvic pain space, you know, which is often associated with dyspareunia and sexual dysfunction. Yeah. So watch this space. It's an exciting time, I think.
Fantastic. It sounds like a very positive note. And I'll just double check. No, we've had another comment coming through saying it's been a great session this evening. Thank you very much. So look, on that positive note, I will thank you again, Alana, particularly for being the main contact in organising all this. Laura and Brooke, really appreciated your involvement and your knowledge and expertise and so on. And look, well done to the three of you and associated researchers, Andrew Briggs and so on, with regards to what is just such an important topic, and hopefully it just gets a lot more coverage. And as I say, I'm sure this recording will be viewed many times by people in the privacy of their own home and so on. I think you've been very encouraging to really sort of give people a little bit of courage to to actually sort of maybe think about addressing an issue if they wish with their health professional next time they see them. So I think we've done well to really bring this to the fore, and it's the first time we've ever covered such a topic in our webinar series over many years. So so I'm really pleased that we've done it tonight, and we'll have this resource as an ongoing resource for people to access. So look, on that note, I'll thank again also Janssen Australia for sponsoring the webinar tonight. Thank you, Alana, Laura and Brooke, and everyone who has joined the webinar this evening. And I wish you all a very, very happy holiday season. Hopefully we'll see you back with our first webinar in February next year. But all have a very nice break and holiday season. Thanks everyone, and good night.
Thank you, Jan. Same to you. Thanks, everybody.
Great. Good to you. Bye.
Bye.
Good night.